I'm going to start us out with just a few questions I see here on a list as well. Do you guys do any genetic testing? There's a question on genetic testing and what is the relevance of gene in terms of risk of glaucoma?
Yeah, I don't send genetic testing routinely in adults. I take care of a lot of children's and juveniles. I think there's a more clear role for genetic testing in those patients. Certainly there's an increasing role for genetic testing in adults, but it hasn't become a huge part of my practice. I think the exception to that is I have some adults I care for, but they developed their glaucoma in childhood. And I just make sure that if the idea of genetic testing hasn't been introduced to them before with respect to thinking about childbearing, I typically introduce that as an idea because it does have some risk stratification significance when young adult patients start to think about entering their childbearing years if they were diagnosed with glaucoma as children.
Alicia, Derek, any thoughts on genetic testing?
Yeah, I mean,
I don't routinely send out my glaucoma patients for genetic testing either, unless they're younger. But I will say that I send out a lot of patients with other optic nerve diseases for genetic testing, like Leber's and different presentations like that. And so as we learn more about genes in glaucoma, I do think genetic testing could be highly beneficial in the future, but it's not something I routinely do right now.
Derek, I know you were going to say something, sorry.
Yeah, so typically in the past, we've thought of genetic testing for those families with a strong, family history. Is there some one gene that explains why that person has glaucoma? And I think what we're doing is we're moving away from that because, yeah, that happens, but it's pretty rare and not particularly useful. What is more useful is understanding a lot of genes that can have a little bit of an influence. And now there is a move to develop panels of genes where we can say, like, look, of these 20 high-risk genes, you possess 5 high-risk alleles, and that makes your risk here versus someone who has only one of those alleles or versions. And so I think look for that in the future where we're using panels of genetic tests to stratify your risk and your prognosis.
That's a great point, Derek. Yeah, there's some companies that are coming out, Avalito and others coming out with genetic testing that'll be more, I think, practical for clinicians as well to test a number of different genes. So fantastic points. I got a quick question here about telemedicine. There's some questions out in the audience about being, let's say, in a rural area and not being near an urban city and not having the access to, let's say, eye care providers. Do you guys do telemedicine? Do you think now with COVID and now we're out of the COVID quote unquote zone, do you feel like you're going to have telemedicine stay with us longer term? And how to use it, how to use telemedicine if you do it. Sarah, what do you thought? Do you do telemedicine right now or do you do any hybrids?
So I'm doing a few hybrids, some kind of scheduled phone calls and video visits for patients who were wavering about surgery and sort of have follow-up questions about decision for surgery. But I would say it's not a routine part of my practice. I think someday we will have the technology to really make it effective, but I think home perimetry is still sort of in its nascent stages. Certainly, home imaging of the optic nerve has a long way to go. And I think without the high quality tech, it's hard to provide the high quality care that we can provide in the office, and unless someone's getting their pictures elsewhere and then you're reviewing them. And I've done that in some circumstances.
Yeah, Alicia, you want to say something?
Yeah, I use telemedicine a lot for the low vision side, like helping make sure that services were obtained, or, sometimes I'll ship a kit of devices to a patient if they live like 5 hours away and then Zoom with them and a caregiver or family member to see which ones work as opposed to making them drive 10 hours. But when it comes to the glaucoma management, I don't do telemedicine because there's not a great way, as previously mentioned, to get good pressure or imaging at home. What I have done is some of my colleagues will do is, say the patient had glaucoma surgery and drove to a big city, like drove, for example, from Maine all the way down to Boston. But then myself or my colleagues may be seeing patients in Maine. I'll do the post-op care and coordinate with the surgeon from the big city in the more rural area, but I wouldn't necessarily say that's telemedicine, more just co-management because I'm more local.
Yeah, I think over time we will see more diagnostic tests being done at home, whether it's field tests that are being done at home, and even potentially OCTs and others. But what I do is, like what Sarah was saying, hybrid visits. They come in for their OCT or field, and I tell them, I call them at home and to interpret with them and explain so that they don't have to stay in the office as long as well. If they can go back home. But yeah, I think we'll see more and more of that hybrid over time as the technology advances for home diagnostics as well. Love to ask a question about steroid. There's a question up top here on steroid response, and is it permanent, and does it go down when you stop the steroid, and how do you treat it? Anyone want to tackle that issue on steroid response glaucoma?
Sure. So for most patients who have a steroid response, when they stop the steroid response decreases, the pressures come back to normal. There is a rare patient where it has stayed up much longer than you would expect it to stay up, but that is really rare. So I think for most patients, you get off the steroid and the pressures come back to normal. And look, for those patients who still need steroid, either because of inflammation or they've had corneal transplants, then there are things that the glaucoma specialist can do to lower the pressure despite being on the steroids. So I think it's okay.
Yeah, and there are different types of steroids too. There's medicine called loteprednol is a molecule which has less chance of causing pressure spikes arises. So that's one thing. And of course, even things like, if someone's quiet, SLT can be an option for those patients as well. So a number of things you can do if needed. But yeah, it does come down most likely over time if you stop the steroid. Let me ask you, do you guys worry about systemic steroids like let's say prednisone pills or steroid inhalers? Is that also a risk for pressure rises?
It is also a risk for pressure rise, although I would say in my practice, I have far more patients who have clinically significant cataracts from their systemic steroid use than have had significant pressure responses from their systemic steroid use. So I think there's good reason to try to minimize the exposure to the extent possible in coordination with whomever the prescribing doctor is.
Right. Patients should know that in terms of risk, if you've had steroids injected into the eye, that's your highest risk. If you're using steroid eye drops, that's lower risk, maybe intermediate. And if you're using inhaled or oral steroids, that's your lowest risk, but there is still some small risk.
Mm-hmm.
Very good points. We talked earlier in the first Q&A about ocular surface disease, dry eye, et cetera. Do you utilize preservative-free drops? Are they out there, and do you utilize them? Alicia, what are your thoughts?
Yeah, we do utilize them. Specifically, we try, if possible, unless someone comes in with very severe glaucoma, to introduce just one drop at a time. So if I'm seeing a reaction from a new drop, like for example, timolol, there is a preservative-free version, or Alphagan, you can switch to Alphagan P. This does sometimes require prior authorizations depending on the insurance, but I do use those drops in patients that have reactions to the drops with preservatives in them.
Yeah, no, I think it's important to realize that preservatives don't necessarily always cause dry eye, but if you have a dry eye, it can exacerbate it as well. So sometimes if you take off the preservative, you don't treat the dry eye, you're still going to have those symptoms as well. So we have to treat the underlying, what we call inflammation of the surface of the eye from the glands that are produced as well. We have some other questions here on how important is it to take the glaucoma drops at the same time as the day? Like, what is the risk of not taking drops at the same time or skipping drops?
So I tell patients, and I'm always kind of surprised about the reaction sometimes, but I tell patients the reason a drop is prescribed as a twice-a-day drop, for example, is because it typically only lasts about 12 hours. So if you're not using it approximately every 12 hours, then the effect is wearing off. And I think, the number one thing is to just make sure you're using the drop. So I tell patients that's my priority. If the use is a little erratic, I'd rather you use it than not use it. But I do think trying to make it part of your routine and using it at the same time every day is important. If for no other reason, then that's the best way to try to remember it. And so I encourage people to use, their morning drops upon waking. And then if they're on a twice daily regimen, that drop to try to use it about 12 hours later. And then I typically counsel them to use the bedtime drops right before bed, and often tell them to keep it by their toothbrush or on their nightstand so that they remember.
And it's so important to realize that some of the medications, like the prostaglandin analogs, and we always dose at QHS, which is right before bed. But honestly, I tell patients, look, and we did a study back when I was at Duke showing that if you took it every day at the same time of day, whether it was afternoon, morning, or evening, it has the same efficacy. So I tell them, look, whatever's convenient for you, take it every day at the same time. Do it with your other systemic pills, if you can remember that way. So as long as you're taking every day at the same time, I feel like that's also as important as well versus skipping. Because if you skip meds, the pressures may fluctuate as well, which we don't want over time as well. There's an interesting question here, a very specific question about CPC. I'm not sure if you guys are doing cyclophotocoagulation, whether it's endoscopic inside the eye or outside, and versus that, let's say, versus a trabeculectomy. Are you doing both, or how would you describe when you'd use cyclophotocoagulation in your practices?
So for me, I mean, I definitely do CPC, and it's pretty much in those patients who have severe glaucoma and have pretty poor vision at that time. They are often very good candidates for CPC. There's also patients where we want to minimize the amount of surgery we do, either because of the quality of the eye tissue or because of other things going on with that patient. So CPC can be a very good option.
How about you, Sarah? Do you do CPC in your practice?
Yeah, I do. I mean, I think glaucoma is a tough enough disease to treat. I think it's important to try to use all the tools we have in the toolkit, and I do virtually all the surgeries. And I think I agree with Dr. Welsby. I mean, I think CPC isn't for every patient, but it has an important role in my practice in the appropriate patient.
Yeah, I have good points as well. How do you help a patient understand when they are not able to drive anymore? Like, do you have a recommendation of when it's time for them to stop driving based upon fields, based upon their comfort level? How do you decide that? Love to hear Alicia's thoughts as an optometrist. What do you tell patients?
So the first and foremost important thing that I tell every patient is if you don't feel safe driving, you should not be driving. So if you've had a vision change where you're like, ooh, there was a couple of close calls, or I'm gripping the steering wheel and I'm really nervous because of my vision, my recommendation would be you should not be driving if you feel that way. Now, with that said, driving legal laws based on vision vary across the states. And so based on what the visual field requirement is in the state where you hold your license, when patients come in, I run special visual field tests that test further out than the traditional 24 or 30-2. So some are like the Goldman visual field or Esterman visual fields to see if you meet the visual field requirement for driving. And then of course, we also check central vision visual acuity for driving. And based on those measurements, I can tell you where you fit on the spectrum of the legal requirements. Now, if a patient meets the legal requirements, but they're a little bit hesitant about driving, I often will work with driving rehabilitation specialists that are people that are trained in helping people with changes in vision or health with driving and deciding if they seem safe on the road or not. And so I'll send for an evaluation with one of those specialists for some patients. But if you don't feel safe driving, I would say don't drive until you feel safe driving again.
Yeah, it's always tough for a provider like us when we have to take a license away from someone. You've taken their independence. It's the last thing we want to do. Thoughts, Derek and Sarah, about how you differentiate which patients may not be able to drive anymore?
I would just say, based on the answer you just heard, it's why I try not to be the one who makes the decision. because honestly, there are low vision specialists, optometrists, vision rehabilitation. They just do so much of a better job than I think I can do and keep track of all the different laws in different states. So I think my job is to connect patients to really the people who know what they're doing in this field.
No, absolutely. There's a question here on, we brought up SLT in the past in the previous presentations, and there was some confusion around cataract surgery and other MIGS procedures. So can you guys explain to the audience, besides SLT, for a standalone MIGS procedure or other surgeries that are minimally invasive, what's available not associated with cataract surgery? Can you remind everybody, Sarah, what are some of the surgeries you can do?
Neither of the stenting options are currently FDA approved as standalone. So the examples of that would be the iStent device and the Hydrus device. And at present, the FDA has only given us permission to use those together with cataract surgery. The other MIGS surgeries can, by and large, be done standalone. So examples of that would be opening the trabecular meshwork with the Cahook blade, which is called a goniotomy procedure, There's a device called the Omni that can both open the trabecular meshwork or dilate Schlemm canal. That can be done alone. A device called a trabectome is similar and can also be done standalone. And then the Zen device, which is slightly different because it makes a bleb. It's a filtering procedure that helps fluid leave the eye through the white of the eye. That can also be standalone. I think one of the challenges is not only what can be done standalone, but also what works well standalone. And I think from an evidence-based perspective, the literature is weaker there than it is in conjunction with cataract surgery. And I think we will know a lot in the years ahead about the role of standalone MIGS and who that's appropriate for. I think the other challenge that's worth mentioning, if you've already had cataract surgery, many of these are potentially good options for you. If you still have your natural lens, any intraocular surgery is going to accelerate cataract growth, at which time you would then be eligible for stenting surgeries also. So I think it always is a challenge to decide whether to enter an eye that still has the natural lens because of the potential to accelerate the cataract.
Yeah, I think you're seeing these companies that do make the stents working on standalone indications, meaning not associated with cataract surgery. And luckily now there are some data sets out there that have a year follow-up with studies like the Omni has their studies, Coke Dual Blade has their studies. So we're seeing more standalone studies coming out, but you're right, there's more robust data with cataract combination, but I think we're seeing the value in those standalone indications as well. What is nice, and I'd love to hear your thoughts on using contact lenses. So from, let's say, Alicia, fitting patients with contacts after glaucoma surgery, do you feel comfortable fitting a patient, let's say, with a post-MIGS procedure versus, let's say, a trabeculectomy in terms of contact lenses?
Yeah, so there's different contact lenses for each scenario. So, there's soft contact lenses, your traditional contacts. And after MIGS, you could definitely use those. The only thing I caution patients with is you don't put your glaucoma drops in your eye while your contact's in your eye. So it can be a little bit of a pain. You have to remove the contact, put the drop in, wait, then put the contact back in. Now, post-trabeculectomy, you can be fit in specialty contacts. There's scleral lenses made that we can have space left for your bleb and things like that. And so there are contact lens specialists that can work to do that once you are fully healed. So yes, contacts can still be used, but we tailor it to the drop schedule and the surgical interventions.
Yeah, I think the fact that you don't have to worry about a bleb with those, the conventional pathway, the inside the eye procedures makes it a little bit easier to wear a contact lens after surgery as well. A quick question on measuring glaucoma versus old age. There's a question is, can you get field loss with old age, or is it only glaucoma? And how to differentiate kind of old age loss of vision versus glaucoma? It's a tough, long question. So anyone have a quick answer for that one?
Well, I think it's clear that there is a loss of optic nerve cells with age. And the question is, when glaucoma causes you to have more than that normal age-related loss, how do we determine that? And as you say, it is challenging in some patients. I will also mention that there is very clear work now that patients who are older lose optic nerve cells faster from their glaucoma. And so age is a very important prognostic risk factor that we as glaucoma specialists need to consider. And the elderly do get worse faster.
Yeah, and we do lose nerve fibers naturally over time, but it is accelerated in glaucoma. No doubt, there's a difference for sure. Absolutely.
But I will say it's worth mentioning as just a follow-on to that question that although the nerve can be damaged from age, you don't expect demonstrable visual field loss from age alone. So I would say if a patient has been told that that is the reason for their field loss, that is worth investigating further. There are many things that can cause visual field loss that aren't glaucoma, but age isn't typically one of them. And I think, patients have to advocate for themselves also, although age does cause things like, challenges with transitioning from light to dark and with contrast sensitivity. Patients should see very, very well into their old age. So if your doctor's telling you that age alone is why you don't see well, I think that requires further investigation.
Good point. That's a really good point, Sarah. And there's certain characteristic nerve changes that occur with glaucoma and field loss with glaucoma versus other conditions. So very good point as well. But we have only a few minutes left. I can't believe how fast the time goes with these question and answer sessions. But for practical purposes, how do you control side effects. Are there any advice that you have for our patients out there controlling side effects of their ocular drop, the topical drops?
I mean, so many
Sarah,
of the side effects so many of the side effects are inherent to the molecule itself and sit better with some patients than others. I think, working with your doctor to customize your treatment regimen and personalize it in a way that works for you is probably best. Some people are simply going to have some side effects from certain medications. I would say generic tips that I tell patients: using an artificial teardrop before you put in your glaucoma drops can help in some cases, especially if burning is something you experience a lot. You don't want to use an artificial tear right after your glaucoma drops because it can rinse it away, but right before can help. Some people find that keeping their drops in the refrigerator makes them more tolerable. Even drops that don't need to be refrigerated can feel more soothing if they're cold. And then using like Vaseline or Aquaphor around your eyelids before you instill a drop, if you tend to get a lot of drip down on your face, can serve as sort of a lubricating barrier between your skin and the drop so that you don't get some of the dermatitis rash type symptoms around the eyes. But I would say finding a regimen that works for you is probably the number one thing.
And it is not uncommon for ophthalmologists to prescribe a drop, see that it doesn't do much, prescribe another drop, but keep the original one on. And so you end up with these patients who have just added multiple medications and they didn't even need the first 2 or 3. So working with the ophthalmologist to kind of figure out what's that minimal amount, what's that minimal set of drops that's going to lower your eye pressure is actually pretty important. It's okay to stop a drop if it doesn't work.
Yeah. And then taking advantage of the non-drop things, which we've talked a lot about. SLT, we've spoken about, the intracameral, the Mataprost implant is an option for some patients. Surgery can get some patients off drops completely. And I've done surgery for no other indication than getting patients off drops. And sometimes that's what's required.
Yeah, I mean, I think that's such an important point. There is a philosophy that's changed a lot now. It's what is the role of compliance in terms of definition of controlled glaucoma? Before, I would say your pressures are fine, your nerves are fine, your fields are stable, you're fine. Even if you can't see because your eyes are so red and dry. But now it's still compliance is an issue. So now that is a rationale for me now, just purely on the ability of patients to stay on medications long-term to go ahead and pursue some type of intervention, surgically or not. So I think that's another kind of change in philosophy as well. Alicia, you were going to say something. Sorry. Did you have a comment?
No, I was just going to say the same thing, that I feel like today, I have a lot more patients that move to surgical or SLT to stop drops than what used to happen, prior.
And the last question I'm going to ask, because we have like a couple minutes left here. I'm going to ask this question as kind of a rephrase of another question from the audience. If you've lost a lot of nerve tissue, right? How do you prevent it from getting worse? In other words, how do we establish target pressure? It's a very long, an hour lecture, I know, but how do you prevent further loss if you already lost so much? It's a tough question. I'll let you answer, Derek. You go first.
I mean, it's almost like asking, so what do I do as a glaucoma specialist, right?
That's why it's a tough one, man.
I would say,
so I think the key.
Oh, go ahead.
Go ahead.
I say,
no, go ahead. Sorry.
We're going to learn what pressure you get worse at. And we also, even if I don't know, let's say it's the first time a patient's visiting me, we know from clinical trials what pressures people tend to get worse at for a given stage of disease. So we make an educated guess about target pressure, and we try to lower you. And we use the tools in our toolbox that are appropriate for that patient. And we basically, it's like a hypothesis. I'm hypothesizing this target pressure is going to be okay for you, but I'm going to prove it to myself by testing that patient frequently and making sure that they don't get worse when they've achieved that target pressure. On the off chance that I was wrong about that target pressure and you need to be lower, well, then we'll see that with the testing because you'll continue to get worse, and we'll reevaluate, lower the target pressure further, and pull out some other tool in the toolbox.
Yeah, the key is that the target pressure is not set in stone. It's evolving depending on how stable you are. And you're absolutely right. Our goal and the trick is for us as providers to find out what pressure we stabilize and what pressure we get worse as well. And that's the tricky thing. But I would tell patients, you have a bucket of nerves. You can lose 10, 20, 30, 40, 50% and not have significant loss of vision. But once you reach that critical threshold, it takes less loss of nerve fiber to cause further loss of vision. So the lower the more advanced glaucoma, the lower the pressure targets have to usually be to protect whatever you have left. Sarah, what are your thoughts on that?
Yeah, no, I agree completely. I think I would just add that the frequency of follow-up matters a lot, particularly in severe disease. I mean, I think even stable patients with severe disease need to be seen probably quarterly. Because as you know, the question asker pointed out, we can't reverse the changes that happen. So we want to catch them if they are happening. And I think the literature tells us that more than anything else, follow-up matters.
Yeah, how often do you follow up your patients who are more advanced, let's say?
I typically do every 3 months for patients who have severe disease. So 4 times a year. And you know, that can feel burdensome for the patient and frankly for the doctor, because in patients who are stable, it sometimes feels like overkill to be seeing them that often. But it only takes one visit where there's a surprise pressure spike or a surprise change on the field to remind you why that's so important. But I tend to do every 3 months for severe disease, 4 to 6 months for moderate disease, and 6 to 12 months for mild disease.
That's great. Well, guys, guess what? We're out of time again. There's so many great questions. To the audience, thank you so much for asking those questions. If we didn't get to them, I apologize. We really wanted to get to every question if possible, but I know the Glaucoma Research Foundation is keeping a track of these questions. We'll try to reach out to you and try to address those at a later date. So we haven't forgotten about those questions. So thank you so much as well. But I also want to thank my panel here. This was a fantastic panel. So much to learn from you guys. I think as a glaucoma specialist, we realize there's no right or wrong answer in almost anything we do. We're all learning from each other, which is why these are such important summits for us as providers as well. So